Welcome. My name is Dr. Sharmila Nandasabapathy, Director of Endoscopy at the Mount Sinai Medical Center. As part of this AGA video forum, I will be discussing an international multidisciplinary collaboration between the divisions of gastroenterology at the Mount Sinai Medical Center, the first Bethune Hospital of Jilin University in China, and Rice University's Department of Bioengineering. As you may know, squamous cell cancer is the most common type of esophageal cancer in the developing world. It has a particularly high incidence and mortality in Central Asia and northern China along what is the former Silk Road. In northern China, incidence rates are 1 in 1,000 and endoscopic screening is being performed. Despite this, mortality rates remain high due to diagnosis at a late incurable stage. The current method of endoscopic screening for this cancer is Lugol's iodine chromoendoscopy with biopsy of Lugol's unstained or abnormal areas. While Lugol's has a very high sensitivity for the detection of neoplasia or cancer, the specificity is poor and benign areas, including areas of inflammation, often appear abnormal, leading to a large number of unnecessary biopsies and increased cost and risk, overall a lower diagnostic yield. As you can see in this image, there are multiple areas that are abnormal on Lugol's, but only the ones encircled in red contain cancer. The green areas are all inflammation or hyperplasia. Confocal microendoscopy, a new high-resolution imaging technology, has been shown to increase the accuracy of Lugol's screening, but current platforms are costly, typically over $150,000 US, and not an option in lower resource settings, including much of the developing world and more rural or community-based settings in the United States. Our group is evaluating a low-cost, a $3,500 microendoscope that may be an option in such settings. This fiber bundle-based system is battery-operated and portable, allowing it to fit into a backpack or briefcase. The 1.5 millimeter diameter optical probe can be inserted through the biopsy channel of any standard endoscope and can be disinfected and reused between cases. When the esophagus is sprayed with a topical fluorescent contrast agent and the probe gently placed against the lining, we have been able to see the epithelium at a 1000x magnification with clear discrimination of normal squamous mucosa, seen on the top, and esophageal cancer, seen on the bottom. In these images, the nuclei appear bright white with topical proflavine contrast. These nuclear features are key in the identification of dysplasia and cancer. The end result is what we call an optical biopsy of Lugol's abnormal areas. We get an image resembling real-time histopathology, which allows us to determine whether the tissue is normal or neoplastic in real time. In a pilot study conducted in northern China, we have been able to accurately differentiate a variety of esophageal tissue types. What was notable was that even novice users, those who had no prior experience with the device, could be trained to identify normal tissue. Our negative predictive value was in fact very high. This is important because it suggests that we may be able to overcome the low specificity of Lugol's staining. Ideally, we want to avoid biopsying or removing Lugol's unstained areas that are inflammatory or benign. What we found was that even novices, those with no prior microendoscopy experience, could be trained to differentiate the normal esophagus from dysplasia from cancer. While this data is preliminary, we are following with a larger clinical trial conducted in both the United States and northern China. We are hoping that this low-cost imaging device can provide an immediate in vivo diagnosis, allowing the endoscopist to remove or destroy precancerous or cancerous tissue immediately without having to bring the patient back for a second procedure.